So I apologize. It was very difficult for me to get everything I want to talk about into 45 minutes here. But if you're ever interested in other talks that I do the OLLI spring lecture series every year, and then I'm looking to do the fall as well. And that's in 4 or 5 parts. So I cover everything I'm doing here in more detail, a lot more detail. And I have a lot of lectures I can always send out to if you guys need more information or just want to read up. Because my goal, and I'll go over why I'm talking about this, is that you may all realize and have found out yourself, if you Google hearing aid or hearing loss, it is a nightmare. For the consumer to understand what they're getting into when it comes to hearing loss, more people are afraid to come and see me for a hearing test than to actually take care of their ear and brain health because of the history of hearing loss, that hearing aids are horrible, that they're just going to sell you something. So we're just trying to constantly squash that here. As the only audiologist for Interior Alaska, we want people to have, at least in our community, a good experience going through this process. Because whether you believe it or not, we will all have hearing loss, and some of you may all experience some form of dizziness that's not a pleasant thing. So why the ear? A few statistics for you guys. It's not something that happens in old age. Yes, you are more likely to have hearing loss as you age, but we're seeing it younger and younger. And people might think, oh, it's because kids use headphones and listen to loud music. It actually has a lot to do with how much medication we take today and how much chronic illness is increasing. And so when you're taking lots of medications, you guys probably have heard of tinnitus or tinnitus. It's a side effect of medications, and so is dizziness, because it actually sometimes is very ototoxic or is affecting the ear over time. The rise in diabetes and other chronic illnesses, they are also aging the ear faster. So while we are seeing more significant hearing loss showing up younger in age, it's not just because of noise exposure, although that does play a role, of course, too. It's also something that we have found to be an invisible disability, something that's very silent to us, no pun intended there. But a lot of people think they hear just fine, and it's because you don't see yourself losing hearing. You don't notice, oh wow, I can't hear that S, or I can't hear CH. Usually, you're also told, oh, your hearing loss is normal for your age. When was the last time somebody told you, oh, that heart attack was normal for your age? You have to start thinking of hearing loss as something that we're going to go through no matter what you think or not, but that it's okay and it's very easy to treat if you're proactive about it and involved in getting your baseline, like you check your eyes and all of that. And then the relationship to a lot of other chronic illnesses and issues such as fall risk, people losing their ability to be safe in their environment. You have to get your eyes checked to drive, but do you ever think about when somebody loses a lot of hearing, if they can't localize where an ambulance is coming from or other sounds? It's still unsafe, but yet it's just not recognized as something that's as unsafe as we really truly believe it is. And you want to be able to communicate, usually, maybe not with your spouse, but other people, your whole life. It's also not just the older people that are aging. We see all the children in Alaska besides the ones that go to Anchorage. And so there's a lot of ear infections that we see. There's children born with permanent hearing loss. Unfortunately, sometimes meningitis becomes part of that. So we do cochlear implants, hearing aids, all the kids. We see a lot of kids that come through the military system as well. So we see all the children from Bassett, unfortunately, that have hearing loss as well. So also why the ears, because people can have dizziness of all forms. And a lot of times, by the time somebody sees us for balance issues, they've been to a million other people. Maybe they've seen a cardiologist or been told just to live with it. But there's a lot of balance portions of the inner ear that can be treated. And we now have the most comprehensive diagnostic equipment for that type of dizziness, whether it's positional vertigo where you roll over in bed and get dizzy, or it was a very severe event where maybe you got nausea and woke up very, very dizzy. So we can help evaluate that as well. And we work closely with neurologists and all kinds of people to help really find out what's going on so you can get back to your everyday life. It's also happening in kids. We see a lot of people with concussions. from sports and all kinds of things, and it can be really, really bad to where they have lifelong dizziness and all kinds of problems. So we do also see children for dizziness as well. So moral of the story is I'm going to talk about all this stuff because it doesn't just have to be part of your aging process. Every day I tell people to stop saying, I don't want to look old and wear this hearing aid. It's actually the opposite. You are doing more for your brain than you are for somebody who's saying, isolating themselves, not getting calls from family members anymore, and just disconnecting. You're doing something to really improve the quality of your life, as well as if you are treating some balance issues too, of course. All right, so the ear. We're going to talk about the anatomy. A lot of people get confused saying I had an inner ear infection or I had this and that, or it was just wax. So we're going to go over this to kind of pinpoint where an issue might arise, and we'll go over disorders that come up in our diagnostic testing with you as well. So the outer ear is what we can look at. The outer ear, we're looking for a lot of skin cancers can start here, unfortunately, because we don't really protect our ears as much as we think we do. So we look to see any malformations or problems here. If someone was a wrestler or maybe got hit in the head, you'll see a lot of cartilage or cauliflower ear. Sometimes you can tell that was in there, maybe in high school or something like that. Sometimes people are born without an outer ear. That's very rare. And you'll see, we'll obviously look down the ear canal to see if there's any problems there. It is not a common thing for wax to be the cause of your hearing loss. It might be part of it, but for it to actually occlude your ear, it really has to build up quite a bit. And I will talk about Q-tips, which are horrible. But the outer ear here, it's just looking at it, making sure there's no infection, anything funky there before we continue our exam going in. The next part is the middle ear. The eardrum separates the outer ear from the middle ear. The middle ear is where sound becomes vibratory. It also is connected to the back of the throat. So if a kid has a cold, it will often turn into an ear infection, unfortunately. And that's because their eustachian tube is horizontal and it becomes vertical over time. So sometimes it'll trap that fluid, creating a perfect area for bacteria to grow. And so you'll see kids sometimes get tubes put in their eardrum to help kind of do the job of the eustachian tube. You can also have problems in that area, like a hole in the eardrum, or you can have the bones kind of get hardened over time, which is called otosclerosis. And we can identify that in our testing as well. All right, so the next part of the ear is the inner ear. This is actually in the skull, and it looks like a snail shape. It also is connected to your balance organ that I'll talk about in a little bit too. So sound comes in acoustically, vibrates through here, and then actually pushes a fluid wave response that hits lots of little hair cells, and that's what gives us the sensation of pitch. So as I'm testing, which I'll go into, I'm looking at every single part of the ear, and I can break that down comprehensively. As an audiologist, or any audiologist, we are the only ones who can truly diagnose if you have a hearing loss. What type is it? What's going on? Do you need a hearing aid, or do you need other things that an ear, nose, and throat doctor can do that I'll go over as well? So what you've got in that inner ear that's like a snail shell is a piano, basically rolled up. So we hear from 20,000 hertz all the way down to 20 hertz, and as you go up or go down in pitch, the wave kind of dissipates and starts to just hit everything that it should as it's kind of transduced in by that vibration. So once all that process happens, whatever we're hearing, all those different waves of fluid hit all these hair cells and then send that sensation to the brain. So it's kind of like a piano is what this picture is all about. The inner ear looks like that, and it has all of these hair cells, thousands and thousands of them. 3 outer hair cell rows, and then an inner hair cell area. These all have to be functioning well to receive that information, sends it to here, and that gives us to our brain to tell us basically what we're hearing, and then our brain interprets all that information. But really, every day, I'm explaining to patients that it's not a volume thing. I am giving you speech and tones to listen to, and I want to see how well you do that in a quiet, sound-treated area. But it's really, what does your brain then do with that? People forget that if you wait, let's say you lost your legs at the age of 40, and you're like, I'm going to get a wheelchair. I'm not going to get prosthetic legs right now. And then at 80, you decide, I'm going to get prosthetic legs and run a marathon. It's going to be great. You're probably not. If you're going to start to lose your hearing from 40 to 50 to 60, and then you wait until you're 80 to get your hearing aids. It's the same idea. That lack of stimulation to the brain and use of duration, intensity, frequency, localization cues, timing cues, all of that hasn't been stimulated in a long time. So think about it as when you're getting your hearing tested, it tells us kind of what's going on, but then how is your brain going to use that information once we get it back, especially because we wait so long to do something. So it's just keep that in mind. It's not your ear that we're really looking at, although it gives us an idea if there's some damage there. We want to know what your brain's going through in the presence of that. A very interesting part of this is auditory memory. So the same part of your brain that deciphers speech and language and produces actual vocalizations is very closely related to the frontal lobe and where we process working memory. And so no, hearing loss doesn't cause dementia and vice versa, but they compound each other. So when someone is predisposed for dementia or is having memory problems, especially recall, short-term recall, what you want to think about is there hearing loss? It's one more thing that your brain is not getting stimulation from the environment from. And so you'll see that memory loss become more severe or maybe onset earlier because they're disconnected from the environment in one more way. So when someone does have memory problems, or full-blown Alzheimer's, a lot of the time we are more aggressive with fitting them with hearing aids or getting them hearing loss treatment simply because we want to give them more of the world while they're going through enough already. So the brain is where it's at. And there's that same area I was talking about. This whole, right in the middle here, it's a very important spot where we decipher speech, where we get timing cues. Is someone asking a question or making a comment? That's on the right side of the brain. And then it all is involved here where we produce speech and where we learn, basically, someone's telling you a number and you auditorily can write it down and remember that. Same idea. And that's why memory is being researched a lot when it comes to hearing loss. And one more slide on that. It's not just about volume, it's localization, spatial orientation, and balance, which I'll talk about how if somebody has a really bad balance disorder, treating hearing loss can really help. Timing cues, when do words end and begin, and of course how we develop language when we're younger. It's very important if you want to have oral language, of course. All right, the vestibular or balance system. So we're going to stay in the inner ear, and what we've got, of course, is the hearing organ, but in the same fluid kind of canals is a balance organ that has a canal for every kind of plane that we're on, horizontal, off-axis, and vertical. And so we have two ears for a reason. It's the silliest thing in the world that people still ask for one hearing aid when they have hearing loss in both ears, because we obviously have two ears for a reason. Nobody asks for a monocle anymore. At least I haven't seen one for 100 years or so. But when you have that localization ability, both of your ears also work together with balance. So if I'm turning my head and looking around the room, my eyes are jumping with my head because my ear is telling them to. So when someone has a dizziness problem of the inner ear, often they'll get something called vertigo, and their eyes will be moving, which is called nystagmus. And that's because there's a disconnect between your ears telling you that you're moving when you're really not. And that's basically what vertigo is. There's also two other organs that tell us about gravity, which is kind of important. And that's part of that positional vertigo, if anybody's ever had that, where you roll over in bed and get brief dizziness. So it's a pretty important little guy in there. I like the ear, personally. Okay, so cutting this down again, you've got three canals. They tell us about how you're rotating in an active movement. And then you have these organs that tell you about horizontal and vertical. Just like if you're in a car, you're not physically moving yourself, but you are moving. And this organ is activated to make sure that you're aware of where you are in space. Or vertically, you're going up in an elevator. You're not physically moving, but your body is. And so those are the different indicators you get. But when it comes to balance, it's always a puzzle. This is my specialty when it comes to audiology. I find it fascinating because I am literally just talking to somebody and being like, what's going on? When did this start? What are your symptoms? Which I'll talk about later. And a lot of it has to do with, okay, I can evaluate the ear, but how's your vision? Are you losing your peripheral? Did you get a knee replaced and now are you off balance? Or do you need some orthopedic intervention? So all of this has to be working okay for us to keep upright. And we work, of course, with neurologists, physical therapists, and all kinds of folks to make sure that we cross everything off the list to diagnose correctly. All right, So the professional, I like to talk about this because I'm heavily involved at the state level, and I was in Vermont as well, with consumer protection. And the problem with everything in America when it comes to hearing aids and hearing loss is you guys don't have much protection. There is some when it comes to the ethical competencies of an audiologist, just like a board-certified MD, but there's a lot of missing information and gaps when it comes to purchasing a device that's not covered by insurance typically. So I'm going to go through who you might see. This is specific to our community, of course. A lot of you may know Dr. Ragas, who's retired, wonderful guy. But we have these two ENT docs here. These guys are going to be the ones who provide medical clearance for hearing devices or determine if surgery is necessary. So as I'm testing the hearing, I'm looking to see, is there a hole in the eardrum? Is it an infection? Is it wax that needs to be removed? Because it may be as simple as that to help treat your hearing loss. If that's not the case, they're the ones who will provide me medical clearance telling me there's nothing else funky going on, go ahead and fit the hearing aids. These guys also will address your sinus issues, your throat issues, all of that as well. So they're, one-stop shop if there's other questions that you have for above the neck. We work closely with a neurotologist in Anchorage who is an ENT that did further fellowship in the brain and the ear together. So he does a lot of, if you have an acoustic neuroma or growth or cochlear implants, he'll do those surgeries there. An audiologist is myself. You'll also see them as an AUD. There are a few master's level audiologists from the 80s and 90s that exist out there, but a lot of them have completed their education to have their doctoral degree. And we're the only ones that are a doctoral level provider that tests hearing for the sole purpose of truly getting down to what's going on. Our goal is not hearing aids, although there will be some private practice audiologists that you can come across that just do that as their practice. But a lot of us are in hospitals or with ENTs together. We do not have to be. We can be completely autonomous and be our own medical professionals. Similar to an optometrist or a pharmacist, same level of education. We can see all ages. So we see adults and children. The hearing aid dealer has a lot of other names as well. Hearing instrument specialist, hearing care practitioner, hearing aid dispenser, like I said. These folks, specifically in Alaska, get a business license. There's no medical education required, and they can screen hearing for the sole purpose of determining hearing aid selection. And so these folks will often have free associated with their evaluation. And that's simply because they can't bill insurance because they're not medical. They're wonderful. They are salesmen and women, and they're there to help you a lot of the time. But because there's no medical education and there is a drive that if they do not fit something on you, they don't have income, that's sometimes the trouble I have. So I've worked with some of them that are wonderful, and then I have also been very wary of others who maybe want to give you something to get you to come in and test your hearing, and sometimes you're not even really a candidate, or sometimes you really should see a physician first, and then there's a little bit of loss of ethics there that occur. So be very careful when you see free. A note about hearing tests is Medicare covers hearing tests once a year at least. If you have a medical condition that's been diagnosed and needs to fall with serial hearing tests, they'll continue to cover it. When it comes to other insurances, if your deductible is not met, yes, you'll have a bill, just like anywhere else that you would go until that deductible is met. But a lot of insurances cover this a little bit differently than vision and dental. It's actually included. So it's not a separate insurance that you need. But a lot of people aren't aware that it actually is covered by your insurance. So a difference here, just to kind of show you, and this is a lot of it's related to Alaska, of course. So we do 8 years of education total. We have to have a state licensure, board certification, or a clinical competence. You can have both if you want, but you have to have one or the other, and that ties us to continuing education of 20 plus hours a year. So we have to stay up to date, like anybody else who's in medicine. We're medically trained, so we do go through a lot of anatomy and phys, very similar to nurse practitioners, again, optometrists, all of that, and then dive into the ear specifically, and then 1 year of residency versus 3 or 4. We can see all ages. Hearing aid dealer, 18 years of age, need a business license here in Alaska, so there's no actual hearing dispensing license like you'll see in some states. It's usually self-trained or manufacturer trained. So what's tricky about these guys is they sometimes will fit multiple brands, but a lot of times they're contracted in with a company. For example, Miracle Ear is just Siemens hearing aids. They have fit them for years together, and you will only get that brand. That's just like going to a doctor that's only going to give you one type of high blood pressure medication. So I have a problem with that. I've always fit multiple brands, and a lot of people are starting to do that, like Costco and things like that, which is awesome. Again, you can only test for the sole purpose of hearing aid candidacy. By law, they're not even supposed to tell you that you have normal hearing. That is a diagnosis. So they can't tell you have this much hearing loss or this or that. You have tinnitus is a medical symptom. They should not be treating that either. But it does slip under the radar for sure. And only adults, they can't touch anybody under 18. So what I often will preach is we shop. We think of pricing when it comes to hearing loss treatment. I don't care where you go for your devices if you're comfortable with that person, but at least get a diagnosis. That's like the number one thing. Come get a test with an audiologist and see really what's going on. Have you looked at every part of the ear? Has a physician maybe had to do a CT scan to see if there's something else going on, or even an MRI sometimes? Don't get caught up in advertising. It should be something that you feel good about, not like because you're getting a Memorial Day sale on a car, okay? Are other treatment options available? Sometimes I've seen people where they've had a unique configuration to their hearing loss, and they actually had a hardened bone that could be removed and replaced. They didn't ever need a hearing aid, but they were never shared that by a salesperson because they were more focused on the sale. So kind of ask questions about the qualifications. You know, do you feel comfortable like this person's explaining everything about this that they should? Do you know what's going on during your test, or is it a rush to sell you something? Because honestly, some people that you'll work with, professionals move from this area, but you should essentially feel like you want to work with that person for the rest of your life. Tell them everything. How is your son doing? How was your weekend? Did you go hiking? You know, it should be that comfortable where, yes, we're treating your hearing loss, but you feel like you can tell them everything about your experience so that it's very personalized. And that's really the drive-home message of all of this, whether you're dizzy or have hearing loss or both. So we'll talk about the hearing. Oh yeah, I did have a slide on this. So hearing loss and hearing aids in general. Medicare is awesome for diagnostics and surgery. They don't like to cover glasses, teeth, or hearing aids, unfortunately. Medicaid is very generous in Alaska, covers everything, no questions asked. And then there's a lot of really great union insurances and Alaska Care. So a lot of retirees have that Alaska Care audio, dental, vision option. Highly recommend that. I wish other states provided that to their employees, but it's really wonderful. And I'm always surprised at how many benefits exist, even if people weren't aware of it, or if they knew they were getting that as part of their package. But we always verify that for everybody to make sure that they're comfortable in whatever they choose to do at our clinic. So I'm starting out with a physical examination. This is a normal ear, and it looks lovely. It's nice and gray. It's got a little cone of light reflection, and there's that first bone that's connected. Love seeing that. This is something that's a no-brainer. Obviously, we want to make sure nothing's blocking the ear before we get started. You can sometimes see, this is a good example of cauliflower ear. So just getting hit a lot wrestling, the cartilage separates from the skin and gets kind of bumpy there. This is an example of the first stages of that. It starts looking like that, and then you can look at that over time. This is just straight up psoriasis. Sometimes people have really dry skin around the ear, which can sometimes build up and cause some impactions as well. So we're looking at the ear and making sure everything's okay before we get started. Inside, I've never seen that, thankfully. These growths are really common, and I have them myself, and it's from swimming in cold water. Your bone will spur out a little bit in the ear. Sometimes if it's like that, they will actually just go in and surgically remove those because they can trap wax and stuff. But sometimes they're not harmful at all. I have them myself from swimming in Maine and the ocean. This is a perfect example of what Q-tips do. You think you're cleaning, but you're actually sticking little fibers of cotton in there and creating a nice block. So we want to make sure that those aren't in the way. We then check the middle ear space with a vibration test. And we can check reflexes too. So right off the bat, we can see if there's fluid, if there's infection, if there's a hole in the eardrum that we maybe didn't visually see. Sometimes there's some wax, but it's not blocking the ear, and this tells us about that too. And so also, if you have an ear that doesn't pop well when you fly, or you have problems with that after a cold, we can address that issue too, which then the ENT will take care of, because that's, that's not something a hearing aid obviously is used for. Problems there, middle ear fluid. There's a lot of fluid there. And then swimmer's ear is another thing too that we see. And that's a really, really bad one. If I'm looking at that, I'm like, okay, we're done. To the doctor. Also, a huge eardrum perforation. There's the bone there, but there's no eardrum anymore. And then there's actually the inner ear that you can see from there. And that's what happened. They used the Q-tip. So actually, I've seen parents do this, unfortunately, with their kids trying to clean their ear. And there it goes. No fun. Very painful. Okay, the audiogram. This is a graph or a sheet of paper that you might see after your testing. The most important part of this to me is speech testing. So we do this because, yes, I want to see how you hear these pure tones, but that's not real life listening. I want to see, with standardized words, how soft you can repeat back ones that you're familiar with, and then give you random words at a calculated volume to see if you're in quiet, you're not looking at me, so no visual cues. How can you hear these words and then repeat them back? Are you just hearing the vowels and maybe, interrupting, your train of thought is interrupted by thinking, oh my gosh, is that a T or an F? So you see those consonants mixed up where you then get a poor score. So you actually get a percentage with the speech discrimination test, and the lower the percentage, the more neural your hearing loss has become over time. So if you've ever talked to a friend or a family member with hearing aids, you know they're hearing well, they wear them all the time, but they just cannot understand you, it's because the hearing aids are doing what they can. It's not that it's a sensory loss anymore. It's that the neural component to the hearing loss is so aggressive that maybe they need a cochlear implant, or maybe their communication needs to be face-to-face no matter what. It's just the nature of their hearing loss. So speech testing is really important to us. Of course, here's the audiogram, which maybe you guys have seen. You've got pitches across the top and volume on the side. We can test everything from very, very soft at 0 decibels down to 120. I'm not sure what 440 is. Never heard of it. So I think this is a typo. But 120 decibels is profoundly deaf. So if you hear some tones during your test, I hope so. Because if you don't, then you have a lot of hearing loss. But yeah, so we can test a very wide range, and we can test sometimes higher pitches during things like high levels of antibiotic use or chemotherapy, because that actually will ruin that high pitch area sometimes during their treatment, and we follow then that person to make sure that they can adjust their dose so that it doesn't completely kill their ear, unfortunately. So frequency by decibel, and we're plotting across for each ear to see what's going on, and then there's a discussion of the discrimination of their brain in quiet, and then also what type. So where was the issue? Was it in the ear canal? Did it involve the middle ear, or was it just sensory hearing? The degree. So we don't do percentages anymore. A lot of people ask for that, but we actually do a degree. So you might be normal here and then slope all the way down here, and we call it mild sloping to severe. Or you might be flat across, moderate. There's all different kinds of degrees that you can have, but that's how we describe the amount of hearing loss you have. And then there's configuration. Sloping is a very common thing because the base area of our ear tends to get saved from noise exposure and general wear and tear. It's the high pitches here, which are the most important for localization, hearing and background noise, clarity. That just gets shot, whether it's noise exposure or just the aging process. But it's also where those hair cells are in the ear. It's kind of like the rug in front of a door. It just gets a lot of wear and tear as the sound comes in over a lifespan. Rising is more likely with an ear infection. This base area, people sound really muffled and mumbled. Or congenital, meaning from birth. Someone can be born with something like that. Flat is very common among hereditary type losses and women. So I often will get a couple in and they swear they both hear differently, or my husband hears really good and I don't because she just has more hearing loss in one area than him, but he can't hear her voice because that's where his hearing loss is. So it's always interesting counseling people, especially couples, on their hearing loss. So they can watch TV together and get along. It's great. So some other things that we've identified as we've tested so far are growth. Sometimes people can have a growth in their middle ear area from having a lot of ear infections. Sometimes people have a growth in their ear canal that is not dangerous but should be removed, kind of like a skin tag. Sometimes it's more serious. It shocks me when I get a patient that's like, oh, this ear hasn't worked forever, I just don't know why. And I'm like, what if your eye went blind? You'd probably be like, oh my gosh, I need to go to the doctor and see what's going on. So when your ears are different, that's not natural. You should have your ears aging the same. Sometimes maybe there's, I'll see a truck driver who has, the window will cause a little bit more hearing loss, but your ears should be the same. So if there's an ear that's different, it can sometimes, rarely, be a growth in the auditory nerve. Sometimes there's ringing in one ear, a little bit of balance issues, and you can be bad enough to involve the facial nerve where you have some tingling on your face. So that's a more serious thing that we diagnose, but if there's ever a difference in the ears, you'll often get an order for an MRI just to double check we're not missing something more serious. And then that's skin cancer. So we see that. It's like a scab that never heals. Noise exposure, we all are gonna have noise exposure to some degree, some more than others. So here's that, the cochlea, the inner ear, looks really healthy, lots of hair cell endings going in. This is the typical presbyacusis or aging process. You'll see some of those things gone, a little bit of aging. This is noise exposure, nothing. And that's that bend in the inner ear I was telling you about. When sounds come in, it's like the first curve. And what you'll see with one gunshot in a lifetime, or obviously multiple when you're just at the shooting range or hunting, it just blasts this area with a very strong fluid wave that just crushes these hair cells, and they just don't have a chance to regenerate and come back up and work again. They're already down and they get crushed again. And that just causes this permanent damage. And that's where all of the speech clarity is. So all of these people will come in and say, I can hear you, but it's just like background noise just ruins it. Or I'm washing the dishes and I just can't hear my husband talking to me, or I can't hear her from across the house, or I avoid this restaurant now because it's just exhausting, or going to an event with family. That's your typical high frequency hearing loss. The age part. So not only do we look at the damage here as we test, but what is that damage done if it's not stimulating the inner ear hair cells and it's not stimulating the nerve? What does that do to the brain? And what we know now is it's reorganizing. And so what I mean by don't wait to do something, at least be aware of if you need to treat your hearing loss, is because atrophy occurs. You're going to lose fibers permanently on the nerve, and then eventually your auditory system in your brain is reorganizing to favor vision, and you're going to compensate very well for that hearing loss. But sometimes that reorganization is permanent. And then I'm fitting you with a hearing aid and telling you this is not going to work anymore. You may need a cochlear implant, or you might have to communicate using a microphone with your family members forever, face to face. And this is real. I talk to people and it makes me very sad that it comes to this point. But it's just simply, a lack of education and not realizing that we're just simply all going to have hearing loss. And it's okay. It's totally fine. Ringing in the ear, hands down, a symptom of hearing loss almost all the time. People often live with this for a long time or are told to. It can be caused by TMJ or jaw problems and also concussion, so there's other causes to it. But almost all the time, it's hearing loss, whether we are picking it up behaviorally or it's still kind of underlying damage, because you could have a traumatic noise exposure without hearing loss and still have like a ringing in your head for a while. It's a real thing that also is psychologically impacted to be made a lot worse. Unfortunately, stress and fatigue and lack of sleep are just major things that can make this a lot worse for someone. And so we actually have counselors in town that help us with folks like that. And that might be veterans, and it's often active duty that we see. And you don't have to live with this. A lot of people are surprised and hesitant to hear that they've got hearing loss, and it's not the tinnitus that's causing their hearing problem, but the other way around. And when they treat their hearing loss, almost always the tinnitus goes away. It's just like you have skin cancer, but you just keep putting a Band-Aid on it instead. You're like, nah, it's cool. If you just treat the main issue that's causing this symptom, often you never have to hear that sound in your head again. So people are blown away by that, but it works all the time. Wax is good. Love seeing it. I like seeing a lot of it. Just kidding. But it's actually something that cleans your ear out. And in a very dry climate that we live in, if people have itchy or painful ears, almost all the time they're not making enough wax. And if you're sticking a Q-tip in there, you're just causing more damage. I mean, I see bruising all the time. I can tell someone's like, no, I don't use Q-tips. I'm like, yeah, you do. And then also you're just making it worse. So let it come out. If you're worried about people seeing it, wipe it away here. You know, it's very simple. If you feel like you have water in your ears all the time, just use an alcohol mixture, rubbing alcohol, and it will help a lot with that. So no Q-tips. Hearing loss treatment. The first thing is, are you truly a candidate? I talked about this earlier. Sometimes people just have an ear infection or wax. Sometimes there's a sudden hearing loss that we can treat in a very small period of time. It's kind of like 48 hours is really the best. Also, sometimes people don't have the ability to wear a traditional hearing aid, or they've had a lot of ear surgeries. And we have access to a bone conduction device now that's similar to a cochlear implant, but goes through your bone. So there's a lot of things available medically that sometimes are the answer instead of a hearing aid. Hearing aids, all about education, which is why every single patient that sees us is going to have a hearing aid education session. It's a lot to think about. Going over your hearing loss, what's your lifestyle like, what's your budget like, what's your health insurance coverage. It's all about making you really comfortable to make that decision. It's an investment in your health, and we want to make sure you're comfortable doing that. And you just really have to think about this as a device that is going to help your brain continue to stay young and connected to the environment. So how to be successful. Provider and prescription is the first thing. You need to be prescribed something and given a diagnosis. That is how you'll be successful. That's how you'll be fit appropriately, which is why we use real ear measurements to fit somebody. It's not about putting you in the booth and saying, do you hear better or not compared to your audiogram? It's about how are you getting sound at your eardrum level to make sure you're not over or under amplified based on your hearing test. It's very, very important that you get a prescription for this, which is provided by an audiologist. Comfort and aesthetics. If a person doesn't like the way something looks, okay, this is a personal sound amplifier, which people rush to buy because it's $29. But yet they balk at something I show them that's very small. It's a weird thing, but you don't have to think of this as your hearing aid anymore. That's not true at all. Hearing aids are so tiny, no matter what you choose, whether it's in the ear or it's the small behind the ear with a wire that comes down. You don't really have an ear mold anymore unless you have a lot of hearing loss. But you should be able to have options to try every style you want. People don't do well because sometimes they're offered something and then they're like, I hate this, I'm not gonna wear this, it's falling out of my ear. Well, come to me, tell me that, and let's work on making it fit better. Maybe the wire needs to be lengthened, maybe you need a different piece in the ear. Maybe we need to remake that. Or maybe this one is really not the answer and you need something like this that's gonna fit just fine next to your glasses and be more comfortable. So it's really about trying different things if you're not quite sure. Your lifestyle. What are your expectations? You're never gonna hear perfectly. We can return your normal sensitivity a lot of the time, but it's not gonna be perfect because it's a very, very special organ that we're trying to make up for. If you want to be able to do everything in the world, you need to think about advanced premium devices. If you really don't do much and you just want to hear the TV and listen in quiet, then tell me that. And we're going to talk about a different kind of lower end device. Not that it's not good enough, it's just what you need. You should never be forced into something that you really, truly don't need. This is an example of that. And you'll be shown something like this, or just different graphs that go over the different features of why premium can handle that, advanced, and then standard. You should be offered multiple levels of technology. How to be successful. Price. So this is another thing, along with those technology levels and lifestyle. Okay, let's talk about price. What's your budget? What kind of benefit do you have? You know what? Maybe we can't afford the premium, but this one might be just fine. Let's try this out. You're going to purchase this, but we can really tweak this a lot to make sure that it's enough for what you need. Are there payment plans? Care credit is awesome, and a lot of people take that. Insurance benefits, we always check that for you. Are you in the service in any way whatsoever? The VA is awesome when it comes to hearing loss benefits. Take that benefit and use it. Other resources like Division of Vocational Rehabilitation or Lions Club, things like that. And then what does the price even mean? What are you getting? You should understand what your warranties look like, your loss insurance. Do you have visits covered, or is it unbundled and really cheap and you had no idea that you're paying $200 a visit? or you're not covered for anything, or your parts and pieces aren't covered. So just really understand what you're getting into when it comes to price. Commitment and communication. Sorry, this is wordy. He's going to put this online for you guys, but you might mostly being quiet, but you really enjoy amazing get-togethers during the holidays. Think about that time when you're doing this. And if you want to be able to use it in those environments, you have to wear them in quiet. Every single person I see as a patient that's not doing well in noise, I can look at their data logging and it shows that they're not doing well in quiet. It's just like back to prosthetic legs. You're not just going to put them on and go for a run. You're going to walk and go through rehabilitation to strengthen those muscles, and then you're going to be able to handle that run. That's your noisy environment with hearing aids. If you're only going to wear them when you put them in, I'm not talking to anybody. Why would I keep them in at home? Because your ears are on. Your ears are always on. So from when you get up to when you go to sleep, you should be able to comfortably wear this, and that's the only way you're going to do well. If you can't, communicating to us. I don't want to see a patient that I haven't seen for 3 months and is like, I haven't been wearing these the whole time. Why? Like, why didn't you call me and come in and get things adjusted if they weren't comfortable? So it's very important that there's good communication, a good relationship, and that you're committed to actually rehabilitating your brain with these. The bottom line is, again, get a diagnosis, be educated. Those consultation appointments never cost anything. Ask lots of questions. I love it when someone's challenging me, except for engineers. Sometimes they want to know way more about the microphones and all that, and I'm like, here's a spec sheet. Have at it, Let me know what you want. And then be committed, because we want to help you. We're not here to make it difficult. We just need to know what your needs are, because even though objectively you've been fit appropriately, it's very subjective, and what you tell us about your experience is going to make it worthwhile for you. So it's a combination. Dizziness. Has anybody here ever had balance problems or been dizzy at all? Yeah. So it can be a very simple thing that we treat with a maneuver, if you've ever done that with a physical therapist, or it can be very involved where we're doing a lot more testing. Migraine is a really big one that we're starting to understand a lot, especially, I don't know if anybody knows anybody that had more issues with balance this spring, but the changes in temperature and pressure are a big problem for people with Meniere's disease and migraine. And so it's been a very busy year so far with investigating this stuff. Luckily in Alaska, again, we have really great equipment, and we have a lot of professionals that are starting to work together versus separately looking at symptoms, and they just don't pay attention to what's really going on with the person. So it's been really great working between people here and in Anchorage. So case history is the biggest thing. I actually, when I see most of the balance patients, and when I get them, the first thing I do is I just sit down and talk. I don't do any testing. I'm just thinking, okay, when did this start? What did it feel like? Don't use the word dizzy. Use something else, because dizzy is an easy thing to say, but it's very much an umbrella term that can mean a lot of things. And if someone all of a sudden is like, oh, when I stand up, I get really lightheaded and I feel like I'm going to pass out, and that's it. That's so much orthostatic type of hypertension things going on than something in the ear. And so very specifically, I can start to rule things out or see if I really need to waste this person's time with more testing that sometimes takes up to 90 minutes. So we really are doing a lot of trial and error just by talking. Did you have any nausea? Were things spinning or very, very vertiginous? Or did you actually black out? Again, cardiology versus ear. Other symptoms. My hearing went when that happened, or my hearing's been fluctuating. I have ringing in my ear. My ear went full all of a sudden. I had pain. The number one thing when someone gets dizzy and has pain in their ear is usually TMJ or jaw joint issues that cause a lot of inflammation. So there's a lot of things I'm starting to kind of keep track of in my mind as I talk to somebody. Ear surgery, that can cause all kinds of issues. Overexertion or overactivity. Dehydration is a huge issue for pretty much everybody. A lot of kids that I see, that's their issue. They started working out, maybe joined a sport, and they're having trouble now that they're not drinking enough water. Not eating for a long time, that's classic, Migraines, family history of migraines, even if someone's had them as a teenager, any major hormonal changes in life can bring on this, and you can have not episodes of aura or pain, but actually vertigo and balance issues. And we can actually look into this along with neurologists to really pinpoint what's going on. One thing as a young professional I had the hardest time doing is simply asking somebody, hey, what's going on in your life right now? I had this woman, I just could not figure out what was going on with her, and she just seemed really stressed out, and I just simply decided to ask her, like, is anything going on? And she's like, yeah, well, it's been kind of tough, I lost my twin sister last month. And I was like, oh my gosh, like, when did this start? And she's like, well, around the same time. And she's trying to handle all of her sister's things and just stressed. She's not sleeping, she's sad. A lot of that. And simply telling someone that there are people she can talk with about this issue helped her. And boom, she's not dizzy anymore. She was just very stressed and going through a lot. So it's always difficult to talk about mental health, but it's real and it exists, and it can cause physiological symptoms, especially dizziness. And then vision. That's a part of it as well, like I talked about before. Has your vision changed? Yeah, I got progressives with 5 different lenses in them. It's crazy. And then more about neurology, but also with vision. You should not have double vision, spots in your eyes, numbness in your face and legs, difficulty with speech or swallowing, a lot of that stuff. I've straight up had somebody basically going through a stroke in front of me when I was in Vermont, and they're there at the appointment. I'm like, I'm glad you made it, but we're going to send you to the emergency room now. It was very interesting. So we see a lot of things that, a lot of people that haven't simply been asked all of these things together, where we're taking the symptoms and really trying to figure out what's going on in that person. Duration, onset, constant versus attacks, that's very important. Does it happen in positions? Head injuries are huge. And then, does anything help or make it worse? And that helps us out a lot, of course, too. I'm also looking at, medical history. What kind of medicines are people on? Do they have a history of blood pressure issues? All kinds of stuff can help. Multiple sclerosis is very interesting. As an audiologist, we identify that issue a lot with really weird hearing testing, being all over the place, and then also their balance just doesn't make sense. And then we'll test them, and there's a disconnect between the eye and ear reflex where they can't follow a target. And so it's been really weird in our profession being the ones to first identify this in people. Not that it's a common thing, but we often are the ones referring for a workup for multiple sclerosis. When it's an emergency, again, this person sitting in front of me can hardly speak and is losing appetite and doesn't really know why he's there anymore. Got him right to the emergency room, of course. But chest pains, numbness and tingling, that's really concerning. Not related to diabetes or anything like that. It's a big no-no. Weakness in the arms or legs, blurred vision, sudden hearing loss. We definitely want to see you right away, but sometimes people, they do need to get worked up for stroke. Severe neck stiffness when it comes to meningitis or other issues back there. And then head trauma and high fever too, of course. That's often, there's a form of herpes that can attack the auditory nerve, similar to shingles, and it comes with a high fever. And I've seen the aftermath of that, but never had somebody in my office, of course, because usually they are seeking emergency help. Common balance disorders, some of you may have heard of these before. There's a lot, don't even worry about reading that, but that's kind of what I'm trying to decipher by just talking to somebody straight off during their first appointment. BPPV, this is the most common. Somebody rolls over in bed, violent spinning sometimes, maybe throwing up even, unfortunately. But it's brief, and you deal with it. You kind of just walk around like this for a little while because you don't want to make it happen. And a physical therapist is the one you want to go to for this. They have the time and the knowledge to treat, especially here. We're very lucky. We have some positional vertigo PTs around. I'll often get this person and then do an evaluation and find out this is the case. I can treat for this. It's just about having time to make sure you're comfortable. And the physical therapist has that. And this is the maneuver. Biggest thing about this maneuver, using gravity to put crystals back into place, is please try not to do this at home. People look up this online, and it's tons of YouTube videos, and then they come in my office or they're somewhere else, and they made it worse because the crystals migrated where they shouldn't have gone because you didn't do this perfectly fluid. So just let a professional guide you through this, and they might give you exercises to continue to get better after that as well. Neuritis or labyrinthitis, this is when that whole balance part and the inner ear part, all of that fluid gets infected by either a viral infection. Sometimes people will say, I got done flying and I caught a little bit of a cold and then woke up with a sudden hearing loss. It just means that the virus got to the nerve and inflamed it a little bit. Sometimes it'll just be a balance problem where you're in bed for a few days, they give you meclizine, Meclizine is great, but should be taken for literally up to 5 days max. They seem to hand it out like candy for the rest of your life, and it's kind of like going to the ER and getting Percocets for the rest of your life. You should stop taking it as soon as you start to feel better. But it can sometimes include the hearing organ too. And we will often, almost always see this person because they're very dizzy, that's passed, but their ear still feels plugged. And again, we have about 48 hours to 72 hours to inject their ear with steroids to try to bring the hearing back if we can. Often we don't see that person in time, and then it becomes a permanent sudden hearing loss, unfortunately. We often will see this person for testing because they haven't gotten 100% better after going through this and just kind of getting better on their own. They still feel kind of off, is what they'll say. Steroid injection, almost always going to a physical therapist as well to just continue exercises to get better all the way. Meniere's disease is way overdiagnosed. A lot of people that have been told they have that in the past, they come back to us, still aren't better because that's really not what they had, but they had symptoms of vertigo and ringing in their ears maybe, and they just were labeled with that diagnosis. It presents itself very similar to migraine and some other things, so we can actually diagnose and piece this out now. Meniere's disease is very severe and can sometimes lead to just lifelong struggles with vertigo, a fluctuating hearing loss on one side that sometimes permanently just stays really bad. They do very well with hearing aids at first, but sometimes it becomes more of a neural thing, like I explained before, where even with the hearing aid working, it doesn't decipher speech well. These folks do well with dietary changes at first, like salt and caffeine, just to regulate fluid in the body. And any stress and anxiety with this is just like tinnitus. It just makes it a lot worse, which is hard to avoid in everyday life sometimes. So we start with the typical diet stuff, and then we go to things like balance rehabilitation with a physical therapist, diuretics sometimes. They do inject steroids sometimes to help the hearing come back. And then surgery, that's when things are really bad. And I unfortunately had a patient with bilateral Meniere's, both ears, and one side was so bad that he couldn't function because of the vertigo. And so that nerve was cut. And that's very severe. You're not going to see people really get that done all the time. He still had a good ear, could still, maintain his balance, but the other side was so bad that there's nothing they could do. They just had to turn it off from the brain, basically. So that's very drastic. We don't really see that much anymore, but it's possible. But as you can tell from everything I've talked about, again, some take-home messages is really that it's your brain you're talking about. So think about you get your heart and your eyes and other things checked because you want to live a long and healthy life and be independent. I just want to start to see the AMA and the FDA talk about just get a baseline, get your hearing checked, make sure you have somebody you're working with, just like your optometrist, to make sure that that's working well so you can communicate down the road. I'd love to see in my lifetime that hearing losses are just caught and we treat and you like them and nobody hates their hearing aids, and technology continues to make them better and better, where there's less cochlear implantation and there's less explain to somebody that I can fit you with these, but you're still not going to be able to communicate unless you are face-to-face with your wife or your husband, because it's not pleasant and it's a tough conversation. But yeah, just think about that, and if you're dizzy, come see me. That's it. And like I said, it's hard because I do like a 5-week lecture on this usually, going into all kinds of fun stuff. But yeah, if you ever need those lectures or want to hit me up for them, they're really good, and the slides are easy to follow, stuff like that. But any questions at all, or? Sure, so I'm going to go back a few slides. So he just asked, once the hair cells lie down and they basically die off because they just can't dance anymore to sound, there are hundreds for each pitch that we hear. So typically, as they're starting to die, there's others that are taking up the slack, which is why I can still on that graph make it louder and louder and louder where you start to hear it again. It can become so loud at some point that it bleeds into the other pitches, which is why some people with a lot of severe to profound hearing loss, they get distortion with hearing aids, because you can't help but if you're making it so loud to stimulate their ear that it actually is affecting other hair cells and other pitches around, which is a tough fit sometimes. But what a hearing aid does is goes in acoustically, and with compression, it's not just amplification anymore. People think of hearing aids in the past being loud and whistling, and they would clip off if something was too loud. we now can take your uncomfortable levels and your threshold and find this new dynamic range to where that damage is there. We can stimulate it enough without, if it's fit appropriately, without then causing damage and creating to lay down those hair cells. But so those hair cells might be gone, but there's like hundreds and thousands of others that we can still stimulate. When it gets to the point where someone still is not hearing clearly, or we cannot stimulate them even to 120 decibels, that's when we need to bypass the acoustic stimulation of those hair cells to a cochlear implant, which that then wraps around the auditory nerve. And it's not, we don't commonly fit cochlear implants, but it's sometimes the last resort. We now have children that have them since birth, basically. But my uncle, for example, he had noise exposure from working in a gear shaper factory, but then also hereditary loss that wiped out the rest of his neural hearing, and so he had to eventually get a cochlear implant. His hearing aids were loud, he could hear things, but they didn't make sense. So that's when we bypass the hair cells, because we can't do that anymore, and then directly stimulate the nerve. That's what a cochlear implant does. Yeah, but and that's why when, also with hearing aids though, you'll have somebody that maybe has a maximum hearing loss from having a lot of ear infections. It's not that their sensory organ's really bad, but to get through that middle ear area loud enough, we have to get a power hearing aid. And that is on the border of causing more damage to the sensory organ. And so what we have to do is, we talk about bone conduction devices. And so I had a picture of that. It's called a bone anchored implant. And it's been really helpful. I've just being up here that's different than other places is the native population with their prevalence of ear infections. We'll see folks who have the hereditary loss and then so much ear infection that wearing a regular hearing aid is very difficult. And so we just bypass the whole system together, which is really neat. It's like, where is it? Where did I put it? Right there. It's like a piercing. A small titanium screw goes into the temporal bone, and it is the hardest bone in the body. And we bypass this whole part and just go straight to the inner ear, into the skull. And they can hear perfectly. They don't have to go through that damaged area. And it snaps on like a hearing aid processor, and they bypass everything. So it's really cool what's available now. Yeah, and cochlear implants are so much smaller now too. You'll just have a little magnet like this now. Children sometimes have the big ones that are fun colors though, so with stickers. But yeah, it's interesting. So I know of a couple Aetna plans that they're tricky, where if you get a hearing test, you have to have a diagnosis of a hearing loss, and then they'll cover it, and then they might not cover some of it until you treat that. So they want to see you go through the whole process, and that's been new. Primera, they have a really nice $3,000 benefit for hearing aids, so I know that. But I've never heard of them not covering it. Did you have a deductible still?
That wasn't the issue.
Huh. I don't know. Yeah.
Pay it because people do.
Yeah, and I'm glad you brought that up. So when it comes to hearing loss also, I'm actually going to be going to Denmark this summer to do some research on the over-the-counter hearing aids and their comparison to hearing aids that are prescribed. And the problem with hearing loss is, how do you know you have a mild to moderate loss? People come in that have severe to profound hearing losses, and they're like, whoa, I thought I heard just fine. I just thought people mumbled, you know? So there's really no way to diagnose yourself what your hearing loss is. You can see through readers and say, oh, that's it. That's the one I need. But what I want people to realize is that when it comes to hearing devices, we plan on offering over-the-counter. We plan on offering personal sound amplifiers. I have some older folks that really don't care. They just want to have these headphones for their TV and be able to communicate with their daughter that visits. And I don't care. I'm not here to push you into something where you don't want to change batteries or charge or wear. You know, it's really what is best for your lifestyle. Yes, that's not prescribed, but I don't care. Like, if that's something you really want to use and you just watch TV, then that makes you happy. Awesome. But I just don't want the counseling and that middle person to be taken away. And that's the audiologist, because I go through the stages of death basically with people. Acceptance. Oh my gosh, I have hearing loss. Okay, now I want to do something about it. It's a very much a psychological process that we want everybody to feel comfortable with. And so we do offer things like accessories that work with your hearing aids to make the TV better. Because sometimes the hearing aid's not enough. Like I said, you need a microphone or something. Or maybe you need TV ears, which is, you can get that online. I just don't want folks to start thinking that, okay, I got this cheap hearing aid and I'm hearing okay, but it's horrible. Why would I go get a regular hearing aid? That should be a stepping stone for you. Okay, I need something, I want to hear better. Now, I feel like maybe I need more, and so I'm going to do something that's prescribed to me so that it's appropriate. Because a lot of people do get, hearing aids, maybe cheap things, and they think they're doing well, but imagine doing even better because someone's medically fitting you and prescribing a prescription that fits your hearing loss. So I'm not against that stuff, it's the future, and I want there to be better pricing. But until, pharmaceutical companies and hearing aid manufacturers make things cheaper, it's just the way it is. And I hate it. I hate talking about price with every patient, which is why I'm excited about, different things that we have access to as medical professionals, like Division of Vocational Rehabilitation, and then being able to bill directly to insurance as well. It's very helpful. Yeah?
Yeah, something's almost loop hearing, do you know?
Sure. So loop hearing, don't let that confuse you with hearing aids. Hearing aids are set up for your hearing specifically. Loop hearing it's been around forever. It's a magnet type of technology, and it was classic in the past. The big hearing aids, cochlear implants, they all had that. That was how you talked on the phone, and that was how when you went to church, you would clip on your T-coil, it was a T on your hearing aid, and it would make the sound system go through your hearing aids using that magnet. It got lost for a while when hearing aids got small. So 2005 to 2010, hearing aids, people wanted them smaller and more discreet, and what got taken out was the T-coil magnet, and antennas were put in for Bluetooth connectivity and all that fancy stuff. Today, T-coils, thanks to the Hearing Loss Association of America, they've been fighting for that to return to hearing aids. So every hearing aid you get today is going to have that T-coil magnet built in unless you go very, very small or in the ear like the one I showed you. So when we're talking to a patient, the idea is to make sure that they realize that they have that or they don't, because, for example, we just worked with Raven Landing to get that funded for them to have a T-coil loop. So we're trying to slowly work our way through the community, and because we have the ability to help provide the funding as like a community, service, we've been doing that to help them get that in more places. And what it is it's a T-coil loop that's put underneath the rug around a room, and it allows you to either access automatically or through a switch the magnet in your hearing aids. Now, some places have just amplifier headphones you can put in, some churches and things like that, where if you don't have a hearing aid, you just wear like the headphones, and it works with the loop as well. But typically they go and work in conjunction with the hearing aid. But that's a great question.
10 years ago, every taxi cab in London had it.
Yeah.
Provided.
Yeah, and the installation up here is pretty expensive. There's nobody locally that does it, and so we worked. There's a place out of Washington that Raven is using, but no, we want to make it more available, and we provided a couple letters to a couple churches. So if anybody ever wants to fight for that, we have a beautiful letter that's hands down. Americans with Disabilities Act supported. So if you ever need that, if you want to fight for that in your community areas, it's a no-brainer. I mean, it's very simple too, because there's a lot of infrared stuff coming out and all those ways to connect with hearing aids, because there's nothing better than direct audio input, which is why when we fit a kid with hearing aids, they automatically get that where the teacher's voice is in their ears all the time. Because even though the hearing aids are helping them, they need to have that direct communication because their face is down writing things and that teacher's walking around the room. We want to make sure they always have that direct connection, which is why FM is also really important too. It's just as strong as T-coil. But yeah, we every single hearing aid we fit, we have a T-coil built in now, thankfully, because for a while it wasn't available. Yeah, it's a great accessory direct audio input source for sure. So with the headphones that we do have ultra high frequency headphones, and they go up to 12,000 hertz max, which is just the capability of how our systems work in our diagnostic equipment. But typically, the biggest thing is when someone has high pitch hearing loss, because we can't go super high, chances are your hearing actually comes back up. We can't predict that, but in hearing aids now, they stimulate out and roll off at 10,000 hertz, where in the past they would roll off at 4,000 hertz. So we actually are able to artificially stimulate out high. Usually it improves music listening. But I have a lot of people that enjoy the outdoors, hunters, whatever, that are truly enjoying that process now. People who do work with birds, just saying that they have never, even when they've worn hearing aids in the past, are hearing that again. But we traditionally test out to 8,000 hertz, traditionally, yeah.
I believe your slide said that Medicare would cover the hearing test if medically necessary.
Yes.
What is that circular logic?
Sure, so even though we're like optometrists and pharmacists, we're like physical therapists when it comes to Medicare billing. And so we don't have direct access yet. I have never had that. So if you come to our clinic, you'll notice, and that's probably what your bill was, is not that you didn't have Medicare, but it's just how we do it. You see us first and then ENT after. And because there's an associated medical doctor that's seen you, it covers that order or that referral. Or you have the ability to just have a referral from your primary care to us. But it has to be associated with a doctor's order.
But it can go either of those two routes, you're saying?
Yep.
One could go to you and then go to the your doctor.
Yeah.
Go to my primary physician and then...
Right, like you could just get a referral from your primary care and just see me. I could tell you everything, send it back to them, and they can give you medical clearance if you want for something, like a hearing aid maybe. But if you don't get a referral, you just want to, hey, I want to get a hearing test, I have Medicare, we would set you up so you get that covered in our clinic. Mm-hmm. Yeah. Yeah, there's nobody that speaks clearly except for an audiologist. No, I'm just kidding. No, actually, my voice changed in this profession a lot to be a little bit more monotone. We do a lot of monitored live voice that has to be monitored by a meter when we test you. But so what we have this brochure in our office. It's called "Communication is a Two-Way Street." And I mean, I could not waste my time. I could spend all my time every single day teaching all professions and all kinds of people how to speak clearly, because they think louder is better. And actually, louder is the worst thing you can do. Yelling at somebody, I would go back in time and apologize to my great-grandfather if I could. I used to just yell at him in his hearing aids. But louder distorts things, and so people speak loud. They don't get somebody's attention first and then start talking about the topic. It can jump all over the place, and then you don't hear the first sentence. And then also traditionally we start out soft, get louder, and then go soft. So in general, I mean, I was thinking about doing something where it's just a communication lecture about how to speak with people who have hearing loss. Our staff goes through that, clear speech, slowing things down a little bit. But yeah, there's not any training. I did some as part of school back home, but nothing that we've done here. But that's a good point. We could go to every group of people and work on that. Yeah.
So you were saying the ringing in the ears is not okay?
No, it's a symptom.
For hearing tests, I've been in 3 times.
Yeah.
And they always say, just ignore it.
Yeah, well, has it been me? No, and that's something that's fairly new too. Tinnitus or tinnitus is being researched a bit like pain. We all perceive pain differently, and it can come from anywhere in the brain, versus an actual thing, or an injury. So traditionally, if somebody isn't bothered by it, it's a symptom that they can kind of ignore. They've had some noise exposure, their hearing is not that bad, and it really doesn't bother them. Yes, you can, learn to ignore it and live with it, maybe use a fan at night, things like that. But if someone comes to our clinic with a main complaint of that, it's really not common for us to just tell you to live with it anymore, because we've seen such successful stimulation. And literally it's because tinnitus devices and hearing aids now stimulate out higher. It's for that sole purpose. It used to roll off before it actually was stimulating where the damage was, that was causing the hyperexcited brainstem and creating the perceptive phantom tone. Yeah, we can actually and now I've seen so many people, like their whole life has changed because they've done that. Even people with normal sensitivity by our standards, but raging tinnitus, and they get hearing aids and they couldn't believe they were fit with them, but they're doing so well because their ambient noise in the room has addressed that issue of your brain just being upset. It's amazing. Yeah, I've been blown away. I've read the research and I was like, okay, but now I've actually seen it, so, yeah.
For 5 years.
Yeah, I totally agree. And again, it's like we were spoiled in Vermont because I was the audiologist diagnosing, giving the devices, and setting this child up for success. But then once they leave my clinic, I have no idea what happens. And there's social aspects. Maybe they're in foster care. Maybe there's these things going on. But we had audiologists for every school region. And so they'd go out, evaluate the space. Do they need towers or do they need an ear level FM? Towers, everybody benefits from, even children with learning disabilities or attention issues, autism, all of that benefits. But you're exactly right that, and up here in Alaska, we have a couple people that are spread very thin but do a very good job in the schools. They evaluate, we recommend whatever direct audio input they suggest, and they have the devices. And the FM compatibility now that are built in. A kid will have hearing aids now that has built-in FM system. They don't need to wear anything else like they used to, and the teacher just wears something that picks up their microphone, or their voice. They make the mistake of wearing it to the bathroom sometimes, which is hilarious. But it's just amazing. And they're so easy to use. They show them how to troubleshoot. There's rechargeable hearing aids now where kids don't have to worry about changing batteries in school. And the nurses are on board. It's just about, and what's cool about schools though is there's a little bit less turnover. It's when it comes to other places, private schools, nursing homes, that's when the high turnover or just the lack of everybody gets whatever they need, kind of falls apart. But we're constantly working on education there. Because you're exactly right. I mean, those systems are wonderful. When you can have it directly to your ear, you don't miss anything, So.
Question something.
So what do you mean? So you're saying that when something like an impact noise happens,
Right, something falls or
it bothers you more than it used to?
or I notice it more.
Okay. So simply, if there's hearing damage, let's say, not only do things need to be louder for you to hear them, but you can also have something called recruitment develop. And that is when just above your threshold where you just barely hear sounds can become painful, especially in the high-pitch area, or shrill noises like a fire alarm, a door slamming, dishes clanging, things like that. So sometimes you can become more aware of them or even be really bothered by them with a lot of hearing loss because your ear, it doesn't have a lot of hair cells left, or it has some damage it doesn't know how to handle. And so if it's just loud enough to stimulate too much of them, it can be bothersome. It's called recruitment. Hyperacusis in people that don't have hearing loss. Hyperacusis and tinnitus go together. If you have ringing in your ears, you always are likely to be sensitive to sounds in general. But also, you could also just hear those sounds better, and you're more aware of them at their normal volume. But yeah, it's interesting. Yeah.
So you mentioned that.
Yeah, if your brain is able to reorganize back and process again with that stimulation, you are a very successful hearing aid user. I see people all the time that with mild to moderate loss, and they have great speech discrimination, 100%. They heard the words perfectly fine at that volume and quiet without any visual cues or context. And I put a hearing aid on them, and they love it from the moment they get them. And they wear them, and they're like, oh my gosh, this is so wonderful. I'm less fatigued every day. We call it almost like a vanilla hearing loss. They just had sensory damage, and they did something right away, and they're doing awesome because their brain, they'll still do better with some vision, because that can permanently change to where we all look at people's faces when we're talking, even with normal hearing, but they've reorganized right back to where they were before, and I do see that. I was trying to find a really interesting research, functional MRI. Here we go. This is cool. So this is normal hearing group and a hearing loss group. This is just with mild hearing loss, you guys, even before sometimes we recommend hearing aids. But they would do stimuli that involved just auditory or vision. And up at the top, if you do auditory, you see the normal hearing loss group. See how much is lighting up in the temporal lobe up front? The hearing loss group, it's hardly lighting up. Auditory, you can see the sides of the brain against auditory system. The visual center of the brain is in the back. So the normal hearing group, when they saw a visual stimuli, their vision lit up. In the hearing loss group, when they saw a visual stimuli, their auditory centers lit up because their brain has become so reliant already on visual cues that it now is using more of the brain for that and focusing on liking their vision. If you've seen somebody that's born with hearing loss, I see kids all the time, and it's difficult talking to parents about hearing loss because they're pretty sure their child's perfect. It's a sad conversation sometimes, but you can watch this child just look at your face constantly as they're talking to you because that's how they're understanding what's going on. So already in this group, your brain's reorganizing to favor vision, and it's because you see something and while you're hearing something, it works together to make that the prominent sense, just like you'd think anything would happen with cross-modality or changes in senses taking over when other ones aren't as acute. So it's very much true. And there's a really neat study after cochlear implantation. Here we go. So let me see what this is, normal hearing. Okay, so visual stimulus in a normal hearing child, the vision center of the brain's lit up. This is how they're predicting some people with hearing aids and cochlear implants over time too. The good cochlear implant performer, after implantation, their occipital or vision center is lit up with the visual cues as well. But someone that's not doing very well, maybe they didn't do anything with their auditory nerve and then got cochlear implants as an adult, their system's lighting up some of the temporal lobe or the hearing lobe. So when they see stuff, they still are using and compensating by lighting up more of their brain, using more of their cognitive load to just look at something or to just hear something. So the idea is that we have these senses that work together, but we compensate so well for hearing loss and get by with it because we can see and we can make up for that stuff and fill in the gaps by knowing context, by telling, oh, somebody's laughing, I'm going to laugh too. Or we just, we can see what their lips are saying, and we get about 30% more of what somebody's saying with that. And so, again, we just think that we're hearing okay. So it's just really interesting. And that's why, with what you said before, what's the deal? Why are we seeing all this stuff coming out of hearing loss and hearing aids? Why aren't they covered? It's Medicare. CMS back in the 70s was like glasses, teeth, and ears are cheap. A couple $100 for a body-worn hearing aid. Why would we cover that? And a lot of research just barely is showing us what this does for the brain. It's always been seen as a luxury, not a medical necessity. And every day I'm like, I'm so sorry that these cost this much, but you're seeing a medical device sticker price, where usually, your pacemaker, you're not seeing what that costs. Your insurance is like, nope, they need that to live, So I don't know what's going to happen in our lifetime, but hopefully the step that they're taking with the over-the-counter hearing aids make people more aware, and they're more likely to do, pay a couple $100 for something. I met with the provider at Costco because I have no problem working with other people that are going to do things ethically. And she was amazing, well-educated. She has an undergrad degree in communication sciences, which is what speech, language, pathology, and audiology do. But the thing is that also she refers when she should. She shouldn't treat anybody with tinnitus. She shouldn't treat anybody with other ear problems or dizziness. If you have a straight-up hearing loss that can be treated by her, she's going to do a great job. But you also have to understand that Costco is a genius business model, and you go there to buy in bulk, and that's what they do, is they buy in bulk hearing aids, previous models from hearing aid companies that have not been sold. We're fitting the newest model because that's what we do. We don't buy in bulk, so we don't get that same pricing. And it's a struggle for audiology because when that started to happen, we're like, what about us? Why can't we get, pricing like you? And they're like, well, you don't have thousands of stores, well, try to beat us, So she's a great person. I just, and the relationship's really good because we do want to help people that have more involved hearing losses from the medical standpoint, but we also want people to have access to cheaper pricing. Just know what you're getting into. Learn about the features. Those hearing aids are de-featured because they are not being fit by a medical professional. So you don't have tinnitus programs, you don't have ways to treat severe distortion with hearing. You don't have 10K roll-off, you have 4K roll-off. Great hearing aids though, so it's just what you need. And if you're not doing well, it's your job to communicate that to her or to who you're working with and try something different. But at least Costco does real ear testing and provides multiple brands. That makes me happy. So, yeah. Any other questions? Yeah.
Just to
Yes, but that's why I don't think over-the-counter and personal sound amplifiers and purchasing things online is the right route that the FDA has gone, because that's where we step in. So I will never have a patient that doesn't know I care, and this is, not every audiologist is like this, okay? There's crappy audiologists just like there's crappy doctors and all that, but what we strive to do here is to make sure that we're checking in with you. Some people don't need us. They're very good at being like, I need help. But if she was all of a sudden not doing well, she needs to tell the person she's working with. And that person needs to be made aware of what specifically is going on, because it's not just a volume adjustment we make. There's noise blocking, wind blocking, all that kind of neat stuff we can do. Or maybe it's re-counseling somebody. There's so much counseling I go through helping somebody realize that this little bit of a hump you're going to go over is going to be tough. I want to make it comfortable, but yes, you have to hear your clothing. You have to hear paper. All of these things your brain literally forgot exist. Let me help you get through that, because once you do get used to that, you will habituate. Just like I hear paper all day long with my normal hearing, but I forget it's there because you have to know it's there, and then, it's not important. So if she was my patient, I want to reach out. So we reach out every 3 months to people, no matter what. Sometimes, again, people are fine, they've worn them forever, and they know when to bug me, which I love. But it might be every 6 months. But so whoever she's working with, either she got lost in the system and wasn't called again, or she just simply needs to step up, because it's an investment, and it's a lifelong adjustment. I mean, you can do wonderful at first, but maybe your hearing changed a little bit, or you have a new environment, you're going to this group, a coffee group now. How can you help me with that? So it's about follow-up, and it's just like a prosthetic legs. Forever your muscles are changing, you need adjustments. Maybe your CPAP needs to be readjusted. All of that is just lifelong. So it's not, and your glasses, you might get along with your glasses for a while until they need to be readjusted as well. So, but there's a little bit of a generational thing I see sometimes where people don't want to bug me. But I'm like, please tell me everything. Bug me, I want to know. Or I'm going to track you down, I'll find you at Fred's and be like, where are your hearing aids? But yeah, so just tell her to speak up. And that's part of that communication thing, because we don't know how to help you unless you reach out. Yeah, for sure. And we want you to do well. I mean, you're investing in something, for your health. So, yep. Cool. Yeah.